Welcome back. You're ready for the last session of the exam. So far, you learned how to write your cheat sheet, how to lead with a great start thanks to an awesome presentation, how to interview your patient quickly and effectively, and how to do the physical examination precisely. It's time to learn how to treat your patient and deliver results. As you can see, this module is not called treatment. Don't even think about treatment. Just think about your findings. Set your priorities as outcome measures and decide the safest and most effective way to improve them. You defined your priorities and renegotiated the goals at the end of the objective assessment. So you know that the patient is on your side. You need to motivate them and lead them through your treatment session and show them how they've improved at the end of it or during the session too. The key factor here is the goals, short and long-term goals. Anything you do from now on needs to have a direct link to the priorities that you established with your patient so far. In every intervention you perform, whether in a manual form or as an exercise or as advice, remind your patient how it helps them achieve their objective or getting a step closer to it. At the end of the assessment, you ask your patient for consent for the treatment and establish the priorities. But now you need to focus on this. During the objective assessment, the patient gives you some key findings related to their condition that you must treat. There's usually many, but you must choose only a few, up to 3 on average. How do you choose? You need to choose the impairments that are impacting your patient's goals the most. Keep it simple, pick just a few and easy ones that you can easily address and reassess. Think about the interview. Think about the assessment, but especially about the last pause moment when you renegotiated the goals. What can you help this patient with so they can be happier and closer to the goals? I really cannot teach you this, but if you come this far in your career and in your exam, I'm sure you will make the correct choice. Patients are actors. They will give you clear indications about their issue, their impairments and their goals during the interview and during the objective assessment. If you follow the structure that I've taught you in this course and you really have the desire to help this patient, you will pick the right ones. I'll talk about all the items in the outcome measure list we wrote at the beginning. Most of them are valid for all 3 clinical assessments, but you'll find more information about the outcome measures in cardiorespiratory and neurological exam in the bonus material. Pain on a scale from 0 to 10. It's one of the most common outcome measures. In the musculoskeletal scenario, you'll decide to treat pain in different ways. For example, in an acute scenario, you might prefer using passive mobilizations. When there's muscle tightness, you can use soft tissue techniques. For example, for a painful pectoral muscle in a patient with rounded shoulders. With long-lasting pain or muscle weakness, you can effectively choose muscle activation and strengthening. Also, it's important to make sure that the patient is compliant with the dosage of medication prescribed or referring to the GP when you think your patient is not managing with the current level of pain. Range of motion with goniometer or tape measure. You only use this outcome measure in the musculoskeletal scenario. In the simulation lab, the actor patient is trained astonishingly well and will show you differences in range of motion during your assessment. You can treat range of motion with muscle activation and active and passive movements within the pain limit. Measure range of motion before and after the exercise. Verbalize the result each time, and you'll notice that the range of motion will increase at the end of the session. Strength from 0 to 5. It's one of the easiest outcome measures. If a muscle group is weak, you'll prescribe a strengthening exercise. That's it. Assess the strength at the beginning and at the end. Verbalize the result, saying, for example, can you feel this is not as strong? You see, you can't push me as hard as on the other side. As a rule, ask your patient to do 1 set of repetitions, like 6 or 8 or 10, and confirm that they're able to do it. Then, you can prescribe 3 sets of those as home exercise program, usually once or twice a day, depending on the stage of your patient. Bam, done. Gait, walk quality and distance. You'll ask your patient to walk in a lower limb scenario or post-operative scenario and very commonly in your cardiorespiratory and neurological cases. In post-operative cases, you need to teach a safe and effective walk, depending on what stage your patient is at. You might need to explain how the restrictions for a surgery impact gait, and to use a gait aid to walk or climb stairs. You'll also need to focus on the gait quality. Correct pattern, especially performing heel-to-toe pattern, proper heel off and clearance during swing, thanks to foot dorsiflexion and hip flexion. Symmetry of stride length and step length. Adequate step width. Adequate weight bearing and knee extension, looking for limp, Trendelenburg and Gower signs. Correcting and repeating the motions that are impaired will make your patient improve when you reassess at the end of the session. Remember to use an encouraging language and motivate the patient, reminding the reasons why correcting these factors are important to reach their goals. Sit to stand, quality and repetition. Sit to stand requires strength, weight bearing, balance and a correct pattern. This is an easy outcome measure for any patient you find on a chair or that you get to stand up from their bed. If you see that their sit to stand is impaired, teach how to perform it correctly and train them to perform it multiple times in a row. For example, you can measure how many they're able to do in 30 seconds with a stopwatch. Remember to assess it at the beginning and at the end, verbalizing the difference, both of quality and quantity. Aid. If your patient's gait is temporarily or permanently impaired, they require a gait aid. If they already have one, you need to make sure they're using it correctly. If they don't and they need one, you need to teach them how to use it. If they have one but they don't need it anymore, or if they've improved, or the weight bearing restrictions post-surgery have lifted, you need to teach them how to wean off it. If you succeed in teaching your patient any of this, you'll have performed an effective treatment. Balance. Balance must be tested and addressed at your patient's highest functional level. During the interview, you'll understand what your patient can and cannot do. During the assessment, you'll decide which level of difficulty you'll test your patient. If they complete the test successfully, you need to increase the difficulty until they can't complete the test anymore. However, if you start testing from a difficulty too high or too low, your assessment will take a long time to be completed. So try to aim straight to the highest functional level. If you find your patient in bed, but you gathered that they have been walking, you could test the sitting balance if you think it might be compromised. However, I would just verbalize your thoughts about it and get your patient directly to walk, especially if this is your patient goal. Education. Anything new you teach or explain is an effective way to treat a patient, especially if they can demonstrate that they've assimilated the new concept or exercise. If your patient is old or distracted, they might have forgotten indications or exercises. You'll teach them again and give them tools to help them being compliant. During the whole treatment, you've been talking, explaining, guiding and encouraging your patient. Always remember to link anything that you're doing back to the patient's goals. You also need to ask for constant feedback. As you start a new technique or exercise, you need to explain what you're going to do and if there's any risk associated with it, for example, pain. You need to instruct your patient about what to do and to stop you if they feel pain. During the technique or the set of repetitions you established, asking, how is it going? Or anything simple like that will keep your patient engaged and safe from overdoing it. The reason why there must not be any moment of silence during your exam is that you need to be owning your exam, covering any topic multiple times, making sure that the patient has understood instructions and is engaged in your treatment plan. Most of all, your mind needs to be like an open book for the examiners. They must know all your thoughts, all the reasons why you're doing certain actions. Both patient and examiners will feel much more at ease and willing to collaborate. Finally, your questioning time will be less tough. Once you've done your treatment, you must reassess the outcome measures in the same way you did during the objective assessment. You must use tools again to reassess quantifiable outcome measures like goniometer, measuring tape, stopwatch. Otherwise, ask your patient to perform the action you want to reassess, an exercise, walking, sit to stand, a movement, and then comment on its quality. You'll find that all outcome measures, only some have improved. So congratulate your patient first, Then tell them how you'll progress with the plan together so that they can keep improving. Finally, the last pause moment. Look at your cheat sheet for one last time. You might have already run out of time at this point, but yeah, it wouldn't be a big deal. This is the moment you try to think whether there's anything you forgot to reassess. Looking at your cheat sheet quickly. Make sure you've addressed the impairment and the goals. You've given treatment and advice about it. And you've reassessed to confirm the improvement. You can talk aloud and summarize as you go through the sheet. If there were other impairments you wanted to address but you didn't have time, you can say that too, mentioning that it can be your plan for the next sessions. Also, check that you've given all the practical tips, referrals, indications to help the patient achieve their specific goal. Finally, ask your patient if there's anything else they'd like to ask or do, and then you can look at your examiners so that they can conclude the session for you. Once you're done, or once the time is up, the examiners will take you back to the reading room and ask you some questions about your exam. The most common questions are regarding these topics: diagnosis, impairments and outcome measures, goals and priorities, discharge plan and milestones, especially in post-operative scenarios, exercise progression, modifications and mistakes. The reason why it's not a big deal if you didn't have time to say everything you wanted in the last pause moment is because as you enter the reading room, you can start talking unprompted and keep going from where you left off with your patient, summarizing the treatment. Just say, I'd just like to conclude what I was saying in the room, which is, don't wait for their questions. Own the room. Do this if you already know that you've made any mistake and you want to rectify it. Also, if you want to be clear about a situation when you didn't verbalize as much as you would have liked to, or about your future plans and progression. You can talk about your concerns or doubts, especially if you're not completely satisfied with your performance. There's a million different ways to look at the one issue, and there's many ways to treat it. So make sure you show your human side and don't be afraid in admitting that you could have done things in a different way, or you were not sure about the patient's feelings or perspective. This will show your examiners you are able to think of different solutions, even if the ones you've implemented weren't the best. If you start talking yourself, once again, you'll demonstrate that you're confident about what you do and you're owning the situation. You also might partially or fully answer the questions that they were going to ask you, which can prevent you from falling into any trick. Finally, either reduce their time to ask you questions in general, and the less they ask, the better, just in case. Congratulations! It was only 50 minutes of exam, but it flew in a heartbeat. If this is your first attempt, you have 2 more sessions to go, so there's no time to relax. You need to write your cheat sheet and do it all over again. But starting with a great success is the best way to boost your confidence. And as long as you stay focused and you keep looking at your cheat sheet, nothing can go wrong, because you were trained so that you can avoid big mistakes. And also, you're trained to pick them up along the way in case you made them. You're surrounded by safety nets and you will pass. If you make small mistakes or later on you realize you could have done things differently, it doesn't matter. These are not vital details that will make you fail. Follow the structure and you will pass. In this module, you've learned how to finish off your exam and deliver a simple and effective treatment, leaving nothing to chance and focusing on goals and findings. In the next and last module, I'll show you exactly what's left for you to study and to practice on, and how to deal with the scariest of all domains, the safety issues. See you then.